This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey guys, welcome to another episode of It's Not In Your Head. I'm Justine Feidelson here with Dr. Dan Bates. What's up, Dan?
Hey, what's up? Not much.
What's up?
I'm good.
Yeah, the usual. Slightly sick.
A couple of days, a little bit sick, but like just boy sick, not real sick. So all good.
Dan's about as good as I am at taking it easy and not doing the things he wants to do. So that's a little frustrating, but
That's true. I got something of a terse text message from my wife telling me to get my ass home because I was like at a meeting and it was gone quite late. It was
Send
getting
Dan
like,
home.
Dad, get home, or
Get
you're not
home.
boxing tomorrow morning. Anyway, like she was like
that's
pissed
it.
with me.
Laying
It's
down the
quite
law.
reasonable actually, but anyway, never mind.
It was fair. I need a little checks and balances too. All right. So we're going to hastily go through, but in good detail, a really good episode today, which I wish the topic was not so near and dear to my heart as far as pelvic dysfunction and in particular SIJ instability. And we'll talk about basically how it presents, what populations it affects, and what you can do about it from both a conservative management perspective with movement and that bucket of things, as well as Dan's area around more of the procedures, kind of going from less invasive to more invasive. We'll get into it, but this is very problematic in particular with the hypermobile patients and that population. That's why I struggle with it. And it's part of the reason why people becoming deconditioned and sometimes told even not to exercise or to avoid movement is an issue because you really, it's a non-negotiable if you have this underlying issue. And some of the things that I've even done from a CRPS perspective, as far as the stimulator, have made it a little bit more difficult to manage. So I'll get into that as well. But first, we'll kind of recap some of the stuff that we talked about in the lower back pain episode. So go back and listen to that one if you haven't yet. And Dan, do you want to go through kind of from a clinician perspective, how you work out, I have low back pain and where is it coming from?
Yeah, where we started from. So where I think about lower back pain, so there's 5 major causes of lower back pain. So facet joints, sacroiliac joints, hips do it, discs do it, nerves do it. So how you work it out, if it's worse in your legs than your back, you start at nerves first. If it's worse in your back, what you do is you split your back up. So if it's above your belt line, start at facet joints and discs. If it's below your belt line, start at sacroiliac joints and hips. And that's kind of just my lower back pain rules of thumb. And it gives you a starting point to start looking for and trying to define where the patient's pain is coming from.
Yeah, narrowing it down.
The whole non-specific lower back pain, so that's essentially where you're unable to define where the pain's coming from. That's an appropriate diagnosis in, the first 3 months or so, where you are, okay, it's acute phases, you treat it and you see if it will get better. And there's a decent subpopulation that will get better. Approximately 30% go on to have longer term pain and 10% go on to have severe pain longer term. So if you're in that group that lasts for longer, then it's time to start looking for what's actually causing the pain.
Right.
So,
and you have a bit of an algorithm for this, right, Dan, to kind of work it out too?
yeah, we can link that. I do have a big algorithm, which is sort of my low back pain algorithm that covers off on everything. And we'll chuck another link up to that on the website for about how do you work through all the causes of lower back pain. I also have an algorithm that's a offshoot from that bigger one, and that is a sacroiliac joint algorithm. And so how do you work through the causes and management of sacroiliac joint pain? And we'll also chuck that one up on the website for people to have a look at. Once again, all these algorithms are essentially thinking tools. They allow you to sort of work through stuff in hopefully what's a logical fashion. Well, it's a logical fashion in my head. Whether that's logical in anybody else's is another thing.
Dan's head is a lot of things, but it is pretty logical. I will say that. Yeah. I mean, and these are helpful too, right? Technically, they're from a clinician perspective and for clinicians, but if you're a patient, it's really helpful because it helps you express what you're experiencing. And if, your doctors or your support team gives you more of a non-specific lower back pain diagnosis, it can help you to better understand maybe what's going on with you and then narrow it down further, even though you're not the doctor. So equally important.
Yeah. On the algorithm, it's also got some pain diagrams, which give you a bit of a hint into what is probably the driver of pain. I think that if you're interested in being able to draw your pain, have a look at the How to Draw Your Pain episode, and then have a look at how that may link in with sacroiliac joint or lower back pain. But over to Juz. So Juz, let's initially talk about how your pain presented, and then let's step back and we'll look at what are the main causes of sacroiliac joint pain.
All right. Well, this is the origin of my wiggles. So all the earlier episodes when I've been doing worse and I have to stand and I look super uncomfortable, this is basically why. And I've struggled with this for a long time. And it's part of why movement became such a passion of mine, because it is so super important to at least keep it at bay and manage it as best you can. And sitting too much in certain periods, and again, for me, the battery creating some inhibition on top of that makes it more difficult to deal with. But the first time I really went through this, it took me like almost a year to kind of get out of a pretty uncomfortable place with and get it more stable to the point where I could sit more comfortably, walk more.
All right, so I'm going to butt in because, like, if we were in a consult now, I would be now going, okay, I need to...
Just wait, I'm getting there.
Hey, I just...
I only want to know this.
I need to ask some questions. I just sit there and go, hey, I'm just going to apologize because I'm going to cut you off a fair few times during this. Please don't take it as inoffensive. I want to hear everything you want to say, but we need to get to the point. So let's get to the point. So, right. Jazz, where is your pain? Let's start with that.
It's basically the top back of my pelvis, kind of along that iliac crest region in particular.
Could you stand up and show us where the pain is?
Oh, you're not going to do that in these shorts. Oh my God. Only because like 10 people watch on YouTube. All right.
Can you point to it with one finger?
No, because it's like...
So it's broad,
so
great.
This is kind of the hot spot. It's worse on the right than the left. And it is broadly going across. Yep, that I Heart New York.
Yeah, great. So what Jazz is showing, she's got pain that's quite broad that extends across her L5 and S1, so over a sacroiliac joint region, and it's broad in nature. Now, the thing that's really good about that is that prior to that, it would have got patients to draw the pain. So they'll draw it, and they draw a broad pain that then wraps across their buttocks and then down over the outside part of their hips.
Yeah, kind of into the greater trochanter area, like that side.
And so there'll be a subset of patients who will also draw over their groin and then over the little bony bit at the front, which is called your pubic symphysis. So when you're getting people to draw their pain, what you'll find is they'll draw three different things. If you are lucky, they'll draw this thing that's golf ball in size. So if it's golf ball in size, you can also ask them, can you point at it with one finger, which is what I did with Juz just then. And what Juz did was exactly what everybody with sacroiliac joint dysfunction does, is they go, oh, no, it's a bit broad like this, where the people who have got osteoarthritis, which is the second most common cause, will generally point at it with one finger. It's not diagnostic, but geez, it's pretty good. And that's called Fontaine's sign. The next thing that we'll do is, so what triggered off your pain?
Yeah. So, and the frustrating part for me is it is pubic symphysis dysfunction. I think even more at the root that leads to the SIJ pain and higher tone. And so when that moves too much for me, that front part, it's a loud kind of, you can hear it. And then it's a real sharp pain at onset. And if you try to kind of on your back, adduct and abduct your leg, it's very trembly. Like I immediately lose all of that stability there. Like Dan said, my groin still right now, because I just heard it when I was in New York, is kind of burny, very achy, like a deep ache. And I immediately feel the change in glute recruitment, right? So glute max kind of checks out to lunch, and then glute med spasming and holding on for dear life. So it makes sitting really, really uncomfortable. Standing and ambulating is not far behind. But if you see someone kind of constantly shifting, Dan can kind of pick patients in the waiting room by how they get up and move around with this type of issue. And so it just very quickly changes the way that you recruit muscles around there, and you get weak where you need muscles to kick in, and then other guys got to pick up the slack.
This is hilarious. Anyway, so what triggered off your pain?
I skipped over that.
You just did exactly what everybody does. I asked one question, and we get this is like, for everybody who is listening, this is this is a standard patient history.
Because I have a patient hat on right now.
And you get told something completely different.
Because it's sensitive information. What triggered off my pain?
No. So what triggered off your lower back pain originally? So you've had it forever.
Yeah. Originally shifting weight. from a CRPS perspective, because I put very little weight on my left side. So that was part, but the underlying hypermobility and the ligament laxity, and then not having the tone and the strength in your muscles to overcome that because of the inhibition from the battery. So post stimulator implant for me, yes, I had some back pain before, but it was not the way that it was the last 4 years. So,
right. So interestingly, for a lot of people, they'll give a story of I fell on my bum. Okay, and so whether it be they fell off like I fell off a horse. That is so common. I fell off a horse and landed on my bum. That's really common. The other thing that's really common is I slipped down some stairs, landed on my bum. And then there's the subgroup. Interesting, there's a subgroup of patients that have it after having babies. So postpartum.
I didn't do that.
Didn't do that. But interestingly, most of those get better. Like 99.99% of everyone who's got, pelvic instability, SIJ dysfunction after having a kid get better, because I don't have like a plethora of people. What I do have though is that a group of patients that, come in mid-40s, they've got ongoing sacroiliac joint region pain. They had pelvic instability during pregnancy. And so that sort of generally fits together in the story. First time I had it was after my first kid or my second kid. And that's kind of really, really common. You mentioned a couple of other things that are common. So pain when people sit. So pain when people go from sitting to standing, because you're basically moving through those joints at that time. Other common things are pain with rolling over in bed, pain with going up and down stairs. Now, it hurts when you go up and down, but if I look for patients who got pain with going down. So if your pain is worse going down than going up, that's now leaning me towards more thinking about sacroiliac joint dysfunction. Then I'll go into looking whether you've got pain crossing your legs, putting on your shoes and getting in and out of the car. Now,
so Dan, it gets to the point where it's like everything hurts, because you just listed like, what do you do throughout a day? Sit, stand, walk, go up, downstairs. So that also makes it hard from a patient perspective to be like, what triggered it? What caused it? Because it's this accumulation of everything is now.
Yeah. The thing that's interesting, what I'm starting to look at there is I'm trying to tease out. So cross your legs, in and out of the car, putting on your shoes. If you've got groin pain, that's consistent with hip related signs. And if your pain gets better when you cross your legs, what that's called forced closure. And so what you're doing is you're closing your pelvis and you're stabilizing your pelvis. And so that's an indication that someone might have sacroiliac joint dysfunction. So those are the things that sort of lean me towards going, okay, I think this is going to be SIJ dysfunction. The other major thing that I'll be looking for in the discussion will be, have you had any inflammatory disorders before? And how long have you got pain for in the morning? So if you wake up in the morning and you've got stiffness for 2 hours, I'm going to lean towards the third main but least common type of sacroiliac joint pain, which is inflammatory disorders. So that's your psoriatic arthritis, your rheumatoid arthritis, your spondyloarthropathies, which are like just a big word for saying arthritis of the back. And so that's the direction that I'll lean to. And then I'm going to be looking for, what have you done for it? So Juz, what have you done for your pain so far?
Oh, stability. Yeah, I've had cluneal nerve blocks too, but that's more of an underlying other entrapment issue. But outside of that, really it's building the underlying stability. And a lot of times when you lose movement at your hip joint and you can't kind of move your pelvis around the femur or your femur the way you should, you're going to move from somewhere else. And so if you aren't moving from there, you put more pressure on and tend to kind of extend more from your low back. And if you lack stability there, that's also a driver of that increase in discomfort. So from a movement perspective, it's a lot of that, reprogramming of your motor patterning, changing the way that you're able to differentiate joints and kind of help your brain learn, no, don't move from here, move from here, and kind of having different techniques from a sensory perspective to give your brain more information to work with and bring awareness to areas of your body that you don't realize you're moving basically instead of where you'd want to move from. So that's part of the challenge when you go into like a typical ortho PT setting, is it's just more clamshells, more side lying leg raises. And if you more is not better. So you have to change the way your brain is completing movements sort of at that automatic default setting, because if you're a car and your tire blows out, it stops. But as a human, when because of pain and dysfunction, you start to learn to work around an area of your body, your brain is just going to figure out another way to reach for the thing up here or bend down for the thing down there. So you can't stay in that same pattern and just load it. Because that was another aggravator of if you're then from a hypertrophy perspective, just working on strength, but you lack the underlying stability, you can often feel tighter. And a lot of hypermobile people have not a whole bunch of ROM because it's deeper in the joint. And then the muscles are holding on and keeping you stiffer. So it's that tricky balance of building stability, gaining movement where you need it, not moving from places that you don't realize you are and you're moving instead of, and then loading it once you're able to recruit muscles more properly and avoid sitting for super long periods, et cetera, which is not helpful.
Yeah, I think the thing that you highlight here is that pelvic stability is about three things. Okay, so it's about bone, which you can't change. It's then about ligament integrity, which is where we talk about the hypermobile piece and essentially the post-trauma piece, and also the osteoarthritis piece. And then the third piece is then about strength. Now, the majority of patients get better with strength work. Okay. And so like millions of people around the world have got sacroiliac joint dysfunction. They are able to go to their PT, their physio, their osteopath, their whoever has the skill base to teach people, lumbopelvic stability exercises, and they get better. And so those people don't need me. And what we're looking for and what I'm looking for is, and this is one of my key questions I asked, is does the physio make you worse? Right. And they're like, oh yeah, I went once, I never went back. They were terrible.
It was the worst.
It was the worst. And I say, so what's happening there is that it's not the physio.
Yeah.
It's the underlying disease process. So for me, if the patient goes to the physio and they get better, and then they come to me because they haven't got better, that's a compliance issue. That is you actually just need to go and do some more exercises. Exactly. Do what the physio, osteo, whoever tells you to do, and do it more than when you go to see them.
Yeah. Okay? In that case, more is better because you can't
more is better.
Do the bare minimum. Yeah.
For the patient that goes to their allied health person and they do something and they blow up in a ball of pain afterwards, what happens there is that the joint itself is a flat joint. So if you can, like what I'm doing, if you're watching on if you're not watching, more the point is to just put your knuckles together and they kind of just fits together like your knuckles like intertwined between each other.
It's a nice fit.
And what happens is that the muscles are stabilizing across that joint and they are holding it together.
Yeah.
And when you go and you get a massage, when you go and get dry needling, when you go to yoga and you then stretch yourself out, then what happens is you decrease the amount of muscle tone across that joint and you stand up and you go for a walk and boom, it moves. And when it moves, everything spasms. And so everything spasms around it. Yep. It is the equivalent. And the way I try and explain this to patients, it's like having a dislocated shoulder. Okay. If you dislocate a shoulder, you can throw as much pain relief as you like at that thing. But what you really need to do is relocate that shoulder.
Yeah. So you have to get to the underlying reason.
Yeah. So this is a sacroiliac joint subluxation. What takes place here is that everything blows up in a big ball of pain. It's such disproportionate pain. You go to the hospital, so you go to the emergency department, someone puts you through the scanner, they find nothing because you can't see this on a scan because the movement itself is so small.
Right. And so, it's not that it's this big movement, but it's more than
it's not like a shoulder that you can see is out when somebody walks through the door. It's and so for me, when I see a patient that has presented to emergency with excruciating pain that's non-responsive to any pain relief and there's nothing on a scan, that's a sacroiliac joint subluxation. And so in that setting, what I do is I have a friendly neighborhood physiotherapist.
Shout out Khan.
Shout out to Khan. And I just send them off to Khan and Khan puts it back in and it's, it's amazing. And what we do after that is we then use a sacroiliac joint belt to then hold the patient together. And so we use a mechanical effect to then hold them together as a means of helping decrease pain. And I think a lot of patients come in and say to me, what are you going to do about my pain relief? And I'm like, I'm going to give you this belt.
Here's a belt. It's like a very underwhelming.
And they're like, what? What are you talking about? I need more drugs. But the drugs don't work. And what you need to do is you need to use the belt. And what the belt do is by holding you together, it allows all those muscles to relax. The spasm goes away, the burning goes away, and that just holds you together. You then need to go and deal with the ligament issue, but that deals with the acute issue as it is.
Yeah. Well, this is one of the topics that is frustrating because you see and hear a lot out there with regards to bracing being bad and bracing weakening you. It's not weakening you. It's putting you in a better position to properly recruit the muscles that you need.
Good topic.
And
Great.
doing what your ligaments should be doing, for lack of a better word, and then helping your muscles actually support that, instead of, like I talked about before, you're in these weird patterns of movement and you just keep recruiting stabilizers for primary movements, which is not, they're overworked and underpaid. So Dan's done a good job correcting this, I think, as much as he can, but it is one of those persistent things out there.
Yeah, so this is a mindset thing. So I see use of sacroiliac joint belts. You can look at it in two ways. Okay. At the moment, most of my physio colleagues look at it like casting. So if I put somebody into a cast and you completely immobilize your ankle as it's healing, yes, your calf will waste and you end up with a little twig afterwards, and it's really hard to deal with.
Hey, don't talk about my CRPS foot like that.
Yeah,
so first year and a half.
So absolutely, if you cast somebody, but in this setting, using a sacroiliac joint belt or a back brace is not a cast. It is more akin to what you do before an Olympic lifter puts 200 kilos over the head. What's the last thing you see them do on the tally? They do up their belt.
Yeah.
And they're doing up their weight belt, which is stabilizing their pelvis, and that then allows them to lift more. And so what I encourage patients to do is see the belt as that thing that allows you to lift more, which will then allow you to get stronger and move past those limitations. So yeah, it's mindset. And if you then look at the data, actually I haven't looked at data on sacroiliac joint belts, it probably is, but there's certainly data on back braces. And so if you look at the back brace data shows that they decrease pain, they improve stability, they improve function. So,
And this is another one of those pieces where, why do people avoid exercise? It hurts. It blows me up. Similarly as going to the PT, getting a massage. So if you can put your body in a better position to not have to spasm as much when you're putting yourself basically through your rehab or your strength training, you're able to have better compliance. You're able to do it more frequently, and you're not dealing with this big downside to doing the thing that you need to do. And a lot of people push through pain, or they push through that discomfort, and that makes it more unsustainable. So you don't have to wear the belt 24/7 all the time. You can wear it intermittently. If you're sensitized in that area, it can kind of be uncomfortable. So, be mindful of the dose response from that perspective. But the other time where it can be kind of uncomfortable is when your pelvis is not just kind of tipped higher, but also rotated, nutated, right, Dan? It's the term for that. Yeah, it just makes you feel more smushed. So that can be a little uncomfortable, but I was sort of joking, but not really. Where with the belt, I'm like, ooh, I feel locked in much better. And then when I take it off, I'm like a baby deer, where I'm like, ooh, and I can feel the difference. And even for me, sometimes the belt gets uncomfortable if I wear it for a long time, but then just take it off, right? Wear it for weightlifting, wear it for when you're walking more, and then give yourself a break.
When I'm consulting, I have a scribe in the room with me, and she calls that the alleluia moment. So we put in the patient that we put the belt on, and they stand up and they turn around, they look at me and go, "What have you done?" And I went, magic. Magic. She looks up at me and gives me the hallelujah moment. Yeah, so it's it is, when it is the underlying problem, it's quite amazing. So there's a couple of other things that are uncomfortable with the belt. Firstly, if you put on a belt and the belt makes you worse, one of them is the joint is impacted, and so that needs to be dealt with. The other thing it can be an underlying disc problem. And so if a lot of the time I'll be trying to work out, is this disc, is this sacroiliac joint? Right. If the patient puts on a belt and that makes them worse, I think it's the increase in intra-abdominal pressure that then causes the disc pain. So similar to coughing and sneezing, which can be associated with disc pain, it makes it worse. The other thing that the belts are uncomfortable for, and people don't use it, is if you've got a bit of a tummy. If you've got a bit of a tummy and you put the belt in, they kind of digs in, and it becomes a non-viable option for being able to use. So
are shorts better?
Yeah, I'm going to do the two shout outs for the companies I use. So there's two companies that I use. One is a company called Sacrofix, who are out of the UK. They do great shorts we've used for a long time. And there's a new company that I use that happened just by chance to be a Melbourne company called Supercore. So SUPACORE.com.
Just ordered some of those.
Did you? Good work.
Yeah.
And they also do a great set of sacroiliac joint stabilizing shorts that are different to the Sacrofix guys. But the whole point is, I think the shorts end up being more comfortable if you got a bit of a tummy, because it holds everything in rather than sort of
band.
Yeah, like a band that digs in and there you go. With using the belts, I think one of the tricks with using belts or shorts is that if you are one of those people that wakes up every time you roll over, so you wake up and as you roll, your pelvis goes blah, and then everything spasms again and it wakes you up, you can actually use the belt overnight. So just wear it while you're asleep. That holds your pelvis together and it improves your sleep. And so, you get the double whammy there. So you've got less pain, improved sleep, away you go. So that's also a nice little trick.
And that's another space where pillows can be helpful, like even the pillow between your legs so that your pelvis isn't in this, your leg isn't kind of pulling down in what you don't realize is an uncomfortable position for a long time. You're good when you're initially in it, but then it becomes uncomfortable and that wakes you up out of sleep. So
okay, great. So that leads into what's causing that. And so what's causing that in many cases is that when you're leaning on your side, like you drop your leg across. When people will say, I lay on my left side and it gives me my right side of pain. So what's happening there is that there's a little tendon on the outside part of your hip called gluteus medius. It's where the muscle attaches. And as you drape your leg across yourself, you're essentially squashing the tendon, like you're getting a compressive effect across bone. And that's what then goes on to hurt. For people that lay on their side, and it hurts, it's a combination of two things. It's a combination of squashing the tendon, and then there becomes this sac of fluid over the top, which comes up, which is called the trochanteric bursa, for just not making it easy. And people get diagnosed with trochanteric bursitis. Yeah. So the interesting thing there is that everybody gets diagnosed with trochanteric. You've got a trochanteric bursa.
Yeah.
And so management strategy then is repeated injection of cortisone into that. And it lasts not very long.
And and again, it does nothing for the underlying reason why that's happening. So it's kind of like a Band-Aid. It's treating an aspect of it, but you got to get more to the root or else you're just in this cycle.
And so for me, what I end up doing is I end up treating the sacroiliac joint dysfunction for those patients because they've had, I've done all my rehab. I've had a million injections into my trochanteric bursa. And the underlying issue isn't the bursa or the tendon, it's the driver is the sacroiliac joint dysfunction, and all those things are secondary issues. So treat the SIJ dysfunction, see if all the other stuff goes away, which in most cases it does. If it doesn't, you then go on to, do some other injection type therapies like platelet-rich plasma, for which there is some data around that's mediocre to good.
Yeah. And we'll get to those treatments in a sec too. And that was one of the interesting things when I was going through this rehab process last time was it actually accidentally, similarly as when I just messed it up, I heard the opposite of that same, but I was doing an isometric adduction with a ball between my legs on my back. And I was just squeezing the ball together and it just accidentally sort of shifted back into where it should have been. And I immediately was like, oh my God, my glutes, like I can feel the stuff that I've been working so hard, and for small periods can get on board. But that was very illuminating because this whole time I'd kind of been chasing my SIJ and it was really stemming from the front. Because once that went back where it should have been, the rest cleared up because now it wasn't my glute med holding on for dear life.
So what you did then, out of interest, is one of the muscle energy techniques for repositioning pubic symphysis.
Yes. And this is one of the positive things that do get done more typically in PT settings. And when I go to PT, this is what I work on, with another person where you can do a lot on your own or with a partner, either against a wall or have them, be that other person. But yes, MET stuff is positive from an SIJ perspective.
Yeah. Okay. Injectables. Should we talk about those?
Yeah. I was just going to say, what other treatments, now that we've kind of gone through the more conservative stuff from a belt and movement perspective, do you move to when those things have helped a bit, but not enough?
So in the setting, what I've got is I'll have a patient that's come in. They've got, actually, before we talk about that stuff, let's talk about inflammatory arthritis. And so management for that, from my perspective, is referral to the rheumatologist. I'll do an MRI beforehand. We look for something that's called sacroiliitis. So we're looking for inflammation of the joint. And then it's a referral off to the rheumatologist for them to work out what's going on. And then they'll manage it as per, your standard inflammatory stuff. For patients that have got osteoarthritis of the joint, so this will be somebody who's a bit older. The thing that we will look at in that setting is going to be radiofrequency neurotomy. So that's when you heat up the nerves to the joint, and it decreases how sensitive the joint is, and will decrease pain on average for about 9 to 18 months. In that setting, when the pain comes back, you just repeat the procedure and, hopefully try and settle down the patient's pain again. There's a couple of other things that you see as well. So far we've sort of talked about, the traumatic patient that falls off a horse or lands on their bum when they're going down some stairs.
I know. I wish I had a more traumatic story. Fell off a horse. I just walked around. That was earlier.
Yeah, you could just.
I'm good.
So you've then got essentially what is the 45-year-old middle-aged female that just. I think what's happening there is you're getting gradual decrease in muscle strength, which is then unmasking the underlying sacroiliac joint dysfunction. They most commonly present with the pain over the outside part of their hips. So that's the trochanteric bursa and the glute med tendinopathies. There's two other subgroups that are quite interesting that you see. Firstly, it's patients with osteoarthritis. So you see this most commonly, I reckon I see this most commonly in the 60-plus-year-old male who's come in that looks like osteoarthritis, but responds really well with a sacroiliac joint belt. And I think what's happening there is that just like every other, like when you look at osteoarthritis in any joint, the joint goes through a phase where it gets gradually more unstable and the ligaments loosen off around it before it starts to then, get really stiff and fuse up again. And so I think that in that loosening phase that you see in osteoarthritis, so that's certainly a group of more commonly males that you see and more commonly over 60. And the last group of patients is the group of patients that have had a fusion at L5 and S1. So if you've had a fusion at the bottom part of your spine, I think that what your surgeon will have spoken to you about is at some point in time, you're probably going to get what's called neck segment disease. And then normally what we talk about that.
Trying to be sneaky.
Sneakily standing up just doesn't work. Anyway, what you'll find is the surgeons will talk about neck segment disease. And normally what we're talking about is that if you've had an L5-S1 fusion, at a later point in time, you'll see L4-5 start to degenerate because you've got increased movement through that.
More movement.
However, when you go down, the increase in movement takes place through your sacroiliac joints. And that increase, now, depending on what data you read, you see that in somewhere between, 19% and 75% of patients. And it's certainly, it's certainly greater than 19%, I would say. So it's a very common presentation for patients who have had L5-S1 fusions. To manage that, essentially it's 3 phases to it. First phase is go see your physio rehab person, see if you get better with that. If you do, great. Second phase is then injection of a sclerosant, which we'll just talk about briefly after this. And then the third phase is go back to the physio rehab person and get strong again. So when we talk about injecting a sclerosant, what we're talking about is injecting certain substances, most commonly glucose, so 50% glucose. Platelet-rich plasma is another one you can use.
That's the Prolo, right? First PRP.
Yeah. Well, prolotherapy, I think, is a global term for injection of a sclerosant. You can have multiple different types of sclerosant, 50% glucose, platelet-rich plasma. Mehurolate, I can't even say it. It's really commonly used in the US. We don't have it in Australia. We generally use 50% glucose or platelet-rich plasma. And when I say 50% glucose, I have to clarify that. It's 50% glucose then diluted with, by 50% with local anesthetic. So don't inject 50% glucose.
Don't go glucosing yourself.
It does hurt like hell.
Well, and it causes a short-term inflammatory response, right? Which is
and so
uncomfortable and painful, and then it gets better because you kind of stick yourself back.
So what you're doing is you're injecting the ligaments that stabilize the sacroiliac joint. It triggers off an inflammatory response, and that lays down more collagen. And you then see an improvement in integrity of the ligament. The joint stops moving so much. Then the muscles don't spasm so much. And it then allows you to, that's when you get back to be able to go on and see your physiotherapist or your rehab person and get going with your strength again.
Right.
Because things are not moving normally and muscle function starts to do what it's supposed to do.
Right. Then you can actually build your fitness without the blowback.
Yeah. With the Prolo, I think our numbers that we have, published by one of my colleagues, Bruce Mitchell, he pretty much found that 40% of patients get significant decreases in pain, really just don't need to do anything else. 30% of patients get improvement enough that they just don't care anymore. And they're like, yeah, it's fine, hurts, but we're good. We're out. 20% of patients, we need to go on and do more. Okay. And so that may be, we need to go on to do a further set of injections. So normally for us, we do a 3 injection cycle. We do that 4 to 6 weeks apart. If you've had improvement, but you're not there, then we'll look to do another 2. And that's when I'll change. So I will these days flip from, if I'm doing 50% glucose, I'll then flip to using platelet-rich plasma because it's a different mechanism of action. So platelet-rich plasma works by releasing what's called TGF-beta, which triggers off a set of cells to then release collagen rather than specifically triggering off an inflammatory response. So that's our 20%. And then 10% it doesn't work for. And I reckon that's probably like lower amount. And that group is the group we send off to think about getting a sacroiliac joint fusion.
More invasive surgery.
Yeah. These days, there's a couple of different types of fusions. There's the type of fusion where you put a couple of screws through the joint and you hold it together. So you're essentially compressing the joint. There's another fusion, which is very common in the US, but we don't have it in Australia. It's a minimally invasive fusion where what you do is you basically put a wedge into the back of the joint. And so what you do is you wedge it apart and that stops it rotating. And they put in a bone block at the same time. So it then fuses over time. And so that technique's been used mostly in patients with an L5-S1 fusion. And so
who then get too much movement.
Yeah, too much movement, next segment disease. That seems to be quite successful in that group. I see a large number of hypermobile patients. And for me, sticking a wedge into the joint that's falling apart, it's never made sense to me.
Right, you're pushing it further apart.
So I think that group needs a compressive fusion rather than a distractive one. But I don't, to be honest, there's no data on that. So that's just pure Dan anecdotal crap.
Less people doing the last resort too. It's a smaller sample size to pick from.
No, and sacroiliac joint fusions, I think they're variably successful. So the ones that I think most successful are the patient that are having recurrent subluxations. Recurrent subluxations, it moves, everything explodes into a ball of pain. It takes a couple of weeks to get back. You get back and then it moves again and it explodes. And you're just in that cycle. That patient responds amazingly to an SIJ fusion because it absolutely changes things enormously.
Yeah, it's like the moment after my pubic symphysis went back and it was like, oh my God, we're in alignment. This is amazing. Yeah, feels so good.
So that's that group. I think that the group that has the ongoing ache with sacroiliac joint dysfunction, I haven't had as much success with fusions with. Now, whether that's because it's an underlying pain problem, look, it's probably a little bit unclear. What we have done with those patients, and so this is one of our less common things that we do once again. If you're in the setting where you've had long-term pain instability, we go through the process of sort out your sacroiliac joint ligaments, so you improve integrity, but then we've still got motor dysfunction.
Right.
Okay. And so you have to get back. And so that's where we go back to, okay, let's go do your rehab again. And you get your rehab going again. But in that setting, there's once again a small subgroup of patients that are just unable to get those muscles to work. And that group, we have used a thing called an L2 medial brain stimulator. I'm not a consultant for them, but I do teach for them from time to time. And this is an off-label indication use. So where we've used it you place some leads over the nerve supply outside the spinal.
Oh, because you're trying to innervate the muscles from a motor
and you innervate the muscles and you basically stimulate the main stabilizing muscle we're targeting is multifidus, and it basically improves multifidus function.
Makes sense.
And this is a device. It is effectively a rehab device, but it basically decreases pain by improving muscle function. And we've had some good success with a reasonable number of patients with that once we've sort of worked through this whole process of improved ligament stability,
Yeah, everything
rehab
else
again,
is
still
checked
not
off.
there. Patient has significant wasting and fatty infiltration of that muscle. That's where we go with that as an option, particularly in a setting where we've got the ongoing ache rather than intermittent subluxations. That'll be my go-to first. And then if we don't get anywhere, then maybe we go to fusion. So fusion's always on the end of my list, certainly in Australia, because we don't have any minimally invasive stuff.
Right. Yeah. That's the last house on the block option. So yeah.
There you go.
Yeah, it's kind of our SIJ episode.
All right, so let's bring it all together. So there's 5 causes of lower back pain: facet joints, sacroiliac joints, hips, discs, nerves. Sacroiliac joints make up about 15% of all lower back pain. It'll be caused by 3 major things: inflammatory disorders, osteoarthritis, and joint instability. Each one of those has a specific way that you can manage it. You diagnose it with a diagnostic block, and I use a trial of a sacroiliac joint belt to differentiate then between instability and osteoarthritis. And if you've got pain that's lasting for a long time in the morning, so 2-3 hours, definitely go see the rheumatologist and tick off that it's not an inflammatory disorder.
Right.
Management longer term is rehab.
No weight room exercise.
And then if it's not getting better and it's unstable, think about injection of some sclerosants, which is platelet-rich plasma or glucose most commonly. For the osteoarthritis ones, you can look at doing some radiofrequency.
Then you work your way to the more severe interventions. So you're going from least invasive to most invasive. And no matter what procedures you're doing, you have to work on movement. You have to work on the brain mapping and the proprioception issues that in particular hypermobile patients struggle with, and differentiating joints better so that you can not sort of overwhelm those areas that they are not what needs to be moving. You need movement elsewhere and you need strength elsewhere. And then that will help all the other therapies that you're doing. Because this is not one of those issues that you can just take a medication for. You can't just get injected for. You still have to build strength around it. Cool. Thanks a lot, Dan. We'll see you guys next time on It's Not in Your Head.
All right. Yeah, bye. Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.